Ladies and gentlemen, I wish to thank the Arab Thyroid Association for the invitation to be part of this meeting. It's a great honor and a pleasure. Unfortunately, I won't be able to take part in the discussion, but if anyone has any queries, questions, or comments, I'll be very happy to receive them by email. My alma mater has been Newcastle University, and I've had a long association with it. And for about 20 years, I taught regularly trainees in endocrinology about how to evaluate the evidence, which is very much at the heart of this presentation. But what I would say is that before one interprets the evidence, there is a process of appraisal, and it is followed by the ultimate verdict. And this whole thing reminds me very much of my late father, who loved to go to the market and choose the fruit. And what he would do is he would look at the fruit, pick it up, feel it, tap it, even smell it, and then at the end of this process, he would choose the one that he thought was best. But the ultimate verdict about his choice was passed later on in the evening when it was actually consumed at the dinner table. And it's the same process, really, in principle, that we follow when we try to understand, appraise, interpret, and pass an ultimate verdict on the scientific evidence. So over the next 20 minutes or so, I'll talk about this, starting with red flags. Then I'll talk about appraising, interpreting the ultimate verdict, and share some conclusions. And the first red flag is about non-peer-reviewed publications. If that is the case, there is really no point in reading it, I would suggest. And there are journals such as this that publish papers that are not peer-reviewed and therefore of questionable quality. A very easy way of knowing whether something's been peer-reviewed or not is to check whether it is included in PubMed or Web of Science or Scopus, because these publication databases only include publications that are peer-reviewed. The other red flag is predatory journals, and this is a kind of rather long definition, but this is a scam. These are journals that don't care about quality. They charge thousands of dollars to authors for processing charges, and the quality of what they publish is highly questionable. Unfortunately, articles published in predatory journals are increasing and have done so for some time. And some of you may regularly receive unsolicited emails and invitations from such journals. And the language that is used is sometimes telling. They use phrases such as "dear solemn scientist," or "I hope everything is groovy at you," or "a righteous reminder, treasured response." So these are all red flags, and such emails belong straight into your bin. In addition, the number of fake publications is progressively increasing, which is a real concern. And the source of fake publications is largely from China, and some from the US and other countries. Another red flag is when you read something and you think, this is just too good to be true. Now, here's an example. Publication about mycophenolate in people with thyroid eye disease, published in a reputable journal. It was peer-reviewed, and this was, on the face of it, a very good study, double-blind, with large numbers of patients. And this was the outcome, mycophenolate results versus intravenous steroids. You can really see that the results were spectacular. And just to summarize them, based on this paper, this had better efficacy than teprotumumab, the most effective drug known for thyroid eye disease. It reduced proptosis even more so than teprotumumab, and diplopia, had fewer side effects, and was 300 times cheaper. And this begs the question, why has such a study not actually made it to the New England Journal of Medicine? Who are the authors, and why are we not all using mycophenolate? Well, the answer is that the same authors claimed equally spectacular responses to a herbal remedy, tripteridium, but that publication was retracted. And indeed, the same study on mycophenolate had the same fate in 2023. It was retracted because there were irregularities relating to the data. Another red flag to be aware of is certain aspects of statistics. So studies that have small numbers of patients with no power calculations. Here's an example. This was a study about somatostatin analogs with thyroid eye disease. It was published in a reputable journal, but there were only 8 patients in one of the arms of the study and no power calculations. Also, one has to be aware of analyses that are made post hoc. And statisticians will tell you that if you torture the data long enough, they will confess. And I think post hoc analysis is such an example. It's been described as data dredging because the findings are often spurious. So what about appraising the evidence? Well, there are 2 ways of doing this. You can get out of this maze the long way around, which takes time and is laborious, or you can take a shortcut and just take a jump. And I'll describe to you the shortcut first. So there is what I call the brand methods. Imagine yourself sitting in a train station, there's no clock, and there's somebody sitting next to you that wears a Rolex, and somebody on your left who wears an unbranded watch bought in the Grand Bazaar of Istanbul. Who would you ask for the time? In the same way, some journals are highly trusted, repeatable, because they have very stringent methodology for accepting papers with high impact factors. And some journals that you've never heard of with no impact factor, you should be more aware of. And then there's the trustworthiness of the author. Here is Anthony Fauci, who is a very well established academic. He has an H index of 236, which is very high. It means that his publications are very highly cited. And here's a non-scientist who has opinions and makes them available to the public. Who would you trust? You can also take the shortcut and go straight to guidelines because they will have done most of the work for you. And most of the time, this is a good way of finding your answer, but not always. And here's an example of 2 guidelines for thyroid eye disease published within about a year of each other that are concordant in most respects, but they differ in one fundamental way. The American and European Thyroid Association guidelines recommend intravenous steroids as first line, whereas the European group intravenous steroids with mycophenolate. So you don't always get the answers from guidelines. Another shortcut is to look at how many times a paper is cited. So if you go to Google Scholar, for instance, and you search for your study, there will be a figure for how many times something has been cited. Now, here's an example of a study published in 2005 in an obscure journal that's been cited only twice, and one that was published at the same time in a reputable journal, which has been cited more than 500 times. The long way around is, of course, takes more time and an effort. And I told you that I've been teaching students for a long time, and one of the questions that I put to them every year is this: which is the most important part of the paper, given that the sections are shown here? And the usual answer that I get every year is this: the method section is the least favorable. And that's not surprising because it's the most tedious and boring part of the paper. But I would suggest that this is the most important part because the devil is in the detail, and you will find the detail in the methods section, because that is where you will find information about study design. And if you look at the credibility in the vertical axis against different study designs, right at the top, the king of kings is the randomized controlled trial studies for interventions. So for all the rest, one needs a certain degree of skepticism. Now, having said that, there are some studies that can only be performed by using a design which is amongst these, like cohort studies. For instance, if you wanted to know the natural history of thyroid eye disease, you can't conduct a randomized controlled trial. It has to be a cohort study. Then it's about patient selection. So usually when we decide to study something, we draw from the population of patients with a certain condition, out of which we select those that are eligible according to criteria that we've devised for the study. Then a smaller number are actually enrolled, and even smaller number actually complete the study. So you can end up with a very small proportion of the total. Then we analyze the data, we interpret them, we draw conclusions, and then we make what sometimes is a real leap of faith. We assume that what we have learned from that small sample can be generalized to the whole population of patients with the condition. And so the next time you have a patient in your clinic with thyroid eye disease and you're wondering about whether to treat a treatment or not, ask your question, how similar or different is your patient from those that completed the study? Here's an example. This is a study that was published in a reputable journal in Lancet Diabetes Endocrinology, and started off with nearly 300 eligible patients. 167 were enrolled, and only 57 completed. And that level of attrition raises questions whether there was selection bias during this process. Another example, a study published in a South African journal, patients with thyroid eye disease, and the demographics were interesting because 80% were men, the mean age was 31, and the majority were HIV positive. And if you think about the kinds of patients that you see in your clinic, 80% with thyroid eye disease are women. The mean age is between 40 and 50, and it's highly unusual for any of them to be HIV positive. So it makes me wonder whether these data are generalizable and applicable to the kinds of patients that you see in your own clinic. The other thing is to look at the methods and whether they're validated. Here's an example. This is a study that I was part of, which looked at octreotide, and the outcome was assessed based on the ophthalmopathy index score, which was something that we devised specifically for this study, but unfortunately was never validated. And not surprisingly, it has never been used since in any other study. The clinical activity score is something that's been used very widely in clinical practice, as well as just about in every clinical study in the last 30 years. But that has not been validated. And this is a small study we did and published recently, just to look at the inter-observer variation. So on the horizontal axis are 9 different patients with different degrees of thyroid eye disease, and there were 6 doctors, all very experienced in thyroid eye disease, that assessed the clinical activity score, and these are the data. You can see they're all over the place, best exemplified by patient 5, where the clinical activity score ranged between 0 and 4. And then you need to ask yourself, how convincing are the results? Here's an example. This is the first teprotumumab study showing the change in proptosis on the vertical axis against time. And the top line is that for placebo. Nothing very much happens. And look at teprotumumab. There is a rapid reduction in proptosis, and the 2 lines deviate from each other progressively. small standard errors, you don't need a statistical analysis. It is obvious that this result is convincing. And you contrast that from another study where drug X was assessed for proptosis before another treatment. These are the data, and the statistics showed that this difference was significant. But how convincing is that? And look out for exaggerations by the authors about their findings. So this drug X that I showed you was claimed by the authors to be beneficial in patients with thyroid eye disease. But I think that is questionable just gazing at those results because there's so much overlap. What about interpreting the evidence? Is the outcome clinically important? And there's the concept of the minimally important difference in thyroid eye disease. There is a statistical way of deciding what is the minimal important difference. And if we look at all the assessments that we do for thyroid eye disease, we don't know what the minimal important difference is, except for the quality of life questionnaire. Another way of looking at this is statistically with effect sizes, Cohen's d, relative risk. The one I like is the number needed to treat. And to my knowledge, the only information that we have in this respect is for teprotumumab. Reproducibility is another important thing. And one of my mentors used to say that you need at least 2 independent randomized controlled trials pointing in the same direction to be confident that something works. And unfortunately, there is a replication crisis throughout medicine and science, with most publications and findings not being able to be reproduced. And if you look at non-reproducibility in thyroid eye disease, there's a long history of it. This is an example of an initial study claiming that octreotide was useful, only to be not possible to be confirmed by 3 other studies. And there are plenty of randomized controlled trials in thyroid eye disease that have been published over the years. But if you look at those that are 2 or more concordant, there's only 3. And if you limit it further to independent concordant RCTs, there's only 2, and none of them is a negative trial. The ultimate verdict is whether something is a game changer and whether we should change our practice in the light of the new evidence. And this very much relies on efficacy versus safety and cost effectiveness. And also, it is important to keep on looking for this even after a drug has come into clinical practice. Because the everyday clinical practice may turn out to be a little different to the randomized controlled trials. And this has been the case with teprotumumab, where relapses from the inflammation from routine clinical practice and some of the side effects seem to be commoner than those in the clinical trials. And so, in conclusion, ladies and gentlemen, I would say, like my old dad, pick your fruit wisely. You can take shortcuts in appraising and interpreting the evidence, but the long way around is preferable and much more rewarding. And finally, unfortunately, fake news in science and medicine is almost as frequent as in politics. Thank you very much for your attention.